Hi, Sark Centeno, and thanks so much for joining us today. Got an interesting set of things to talk about. Basically, we're going to focus today on the stellate ganglion and the vagus nerve. Sorry we're running so late today. I was in Scottsdale lecturing at a medical conference and just got back from the airport, so couldn't do it this morning. So anyway, again, going to be talking about those two key drivers of the sympathetic and the parasympathetic nervous systems, the stellate ganglion and the vagus nerve, and how either stimulation or blocking each of those would affect somebody. And obviously, this interfaces with craniocervical instability, this interfaces with long COVID, this interfaces with lots of other things out there. And so I thought it would be a good one because each of these nerves does something different. And you often hear about one being talked about and then another being talked about, but rarely do you hear about both being talked about. Obviously, all of this interfaces with POTS as well. So lots to discuss today. As usual, I'll get into all of that. And then I'll take questions as well. And the questions could be about this topic, could be about any topic at all. Let's see here. Let me go ahead and add this. So the title for today is the yin and yang of the vagus nerve and stellate ganglion. And so again, these are two nerves that do two completely different things. They're part of the sympathetic and parasympathetic nervous system. And activating one gives a very different result than activating the other one. So if we get into anatomy here a little bit, stellate ganglion lies very deep in the cervical spine, shown here at around, looks like C5, 6 there. So it's this down here. So it's lying just above the longus colli muscles, which are the muscles that go up and down the neck, very, very deep to the neck. And those are muscles that help with your ability, for example, to look up. So as you look up, the longus colli muscles are having to slowly allow each vertebra to separate. And so the stellate ganglion is part of the sympathetic chain. So you can see here there's a superior cervical ganglion and then a middle cervical ganglion and then this stellate ganglion down here. And all of that's part of the sympathetic chain, which is part of the sympathetic nervous system. And we'll get into what the sympathetic nervous system does. Vagus nerve, as you've probably seen, runs right in front of the transverse process of the atlas. And by running right in front of the transverse process of the atlas, it can get irritated in cases of craniocervical instability. The vagus nerve controls the parasympathetic nervous system. So the opposite, if you will, of the sympathetic nervous system, and we'll get into that in a little bit. Now, interestingly, they're in close proximity to each other. So if you look at this cross-section here, you have the sternocleidomastoid, and just under the sternocleidomastoid, you find the vagus nerve, which lives in the carotid sheath here with the internal carotid artery and the internal jugular vein. Now, over here, we see the stellate ganglion. So the stellate ganglion lies just a little bit deeper than the vagus nerve. And frequently, when we treat the vagus nerve with hydrodissection, there's no doubt that we're also probably treating the stellate ganglion. And there are things you can do to maximize the treatment of both of those together. So again, these nerves live in close proximity to each other, the vagus nerve and the stellate ganglion. Now, this is lower down in the neck than I showed you before. That was higher up at C1, C2. But realize that a nerve is a little bit like a fire hose, meaning that it's got its cell body, but it's an elongated cell. So each nerve is one elongated cell. So for example, for the nerves that go to my hand, right, the cell body, if you will, meaning the nucleus of the cell lives way up in my spinal cord here, or the dorsal root ganglion. But the actual individual cytoplasm of that single cell extends all the way out to my hand. So what you do to one part of a nerve tends to happen to all of the nerve, meaning we don't have little itsy bitsy, segments of nerve cells going all the way down. It's a single cell. So the yin and the yang. Now, this is really the parasympathetic and sympathetic nervous systems. Yin, chill out, digest, repair. Yang, fight or flight. So the yin is going to be the parasympathetic nervous system. And when that's activated at night. We need to repair our bodies. We need to digest our food. We need to chill out and shut down our brains so that our brains can do their dreaming thing, which helps us to form and consolidate memories and learning. The opposite of the yin, or the parasympathetic nervous system's opposite, is the sympathetic nervous system, the yang, fight or flight. So in that case, we need to get the heart racing faster. We need to increase reaction time. We need to release a bunch of endogenous hormones like epinephrine to amp things up. So each of these nerves is going to control one of these functions. So if we turn on, and regrettably this didn't do so well when it got imported into StreamYard, so still learning here with these slides in StreamYard, but stellate ganglion down here. So if you turn on the stellate ganglion, you get into fight or flight mode. Now, you can turn something on or activate it, turn a nerve on or activate it, and you can go the other direction. You can irritate or block that nerve. So if you were to perform an anesthetic block of the stellate ganglion, or if you were to irritate the stellate ganglion, you'll get into chill and repair mode. So you can take, for example, a soldier with PTSD, and you can block the stellate ganglion and get rid of that constant fight or flight mode that they find themselves in with PTSD related to war, for example. That's really where stellate ganglion blocks originated, if you will. Now, vagus nerve, we can do the same thing, right? We can irritate or block the vagus nerve, then that's going to cause fight or flight. We can also turn on the vagus nerve, and that's going to cause chill out and repair. So as you can see, activating one of these or blocking it has different things that it can do, but really, they're really just two sides of the same coin. Now, stellate ganglion blocks. Now, these work well for resetting the system for PTSD. For example, PTSD related to war, as I've already discussed, was really where stellate ganglion blocks became popularized. The first doctor to use them that way that I know of was Sean Mulvaney. Sean was a Navy SEAL and also a physician. So he had the responsibility of taking care of guys deployed onto frontline combat situations. So they work incredibly well for that, because what they do is they reset the central nervous system around that fight or flight response. Now, it works less well if there's been damage to the sympathetic nervous system, to the stellate ganglion or the sympathetic chain. So that's where stellate ganglion blocks really will help for a little bit, but you'll have to keep getting them on an ongoing basis if you want to maintain that state. Now, if the nerve is damaged, can we promote nerve repair? And I've talked about this before. We've got very good evidence that the growth factors in platelets can promote nerve repair. We have that from in vitro models, meaning in the lab models. We have that from animal models, and we have that now in clinical randomized controlled trials. So there seems to be mounting evidence that putting platelet growth factors around damaged nerves can help repair those nerves. So basically, platelets contain nerve growth factor, which helps nerves repair, as well as VEGF, vascular endothelial growth factor, which helps nerves reestablish their blood supply. So there's things in platelets that can help nerves. And one of the ways to treat a nerve with platelet-based growth factors is to do hydrodissection. And really all that means is injecting those growth factors around the nerve to break open any scar tissue, but also to make sure that the nerve has access to those growth factors to help it repair itself. Now, treating the vagus nerve, we routinely dissect underneath that sternocleidomastoid with platelet growth factors into the superficial cervical plexus. The vagus is also right there, and as we've just talked about, the stellate ganglion is just about a centimeter deep to that. So all of these nerves kind of live in this same area, the superficial cervical plexus, the vagus nerve, the stellate ganglion. And so, for example, here as a cross section here, the sternocleidomastoids, this is what we would see under ultrasound. This is the internal carotid artery or common carotid artery. This is the internal jugular vein. That's the vagus nerve. And then the stellate ganglion lives just down there. So you can actually treat these nerves with platelet growth factors. So one of the things I wanted to announce today was a pilot study that I'd like to do. And that is, I'd like to take 10 patients who had previously responded very positively to a stellate ganglion block, but that only provided temporary relief. Now, I don't want these patients to have evidence of craniocervical instability because we're not going to be treating their craniocervical instability. We're going to be focusing simply on placing platelet growth factors that can help repair nerves around these two nerves, the vagus nerve and the stellate ganglion. And the patient has to agree to fill out pre-outcome forms, 1 month, 3 months, 6 months, 1 year. There'll be no charge for these injections. Just trying to get a good sense of how patients without CCI respond to this, because we're starting to see our CCI patients respond quite well, but we're also treating their CCI. And I know there's lots of other patients out there that have vagus nerve issues, that have issues with that fight or flight response in stellate ganglion, who I think would benefit longer term if they got a platelet-based injection, in the same way that if I do a steroid epidural in someone, I can give them a month or two of relief from a pissed off nerve in their back. But if I do that with platelet growth factors, that goes to 6 to 12 months. So that's really the goal here. So if you're interested, reach out to me. It's going to be an informal 10 patients, just trying to get a sense of how all this stuff goes for that patient population. I'll also put this on some of the Reddit threads and social media, Facebook groups, etc., because I think this will be an interesting approach to try to see if we can get a much longer response out of patients who have previously responded to just a numbing block, and but it was really short term for them. So can we make it last 6 or 12 months is the question. And can we repair the nerve for good is the other question. So let's go to questions now here. I got a bunch. So let me get out of that thing in StreamYard. Lindsay, I had 2 successful treatments of stellate ganglion block, but the last series didn't help. Will PICL give different results because the area is actually getting treated? Yeah, Lindsay, so if you've got craniocervical instability, then yes, we can treat both the vagus and the stellate ganglion. And at the same time, obviously treat probably the cause, the irritation of the vagus nerve through craniocervical instability. Lindsay, the stellate ganglion block helped reset my debilitating autonomic nervous system symptoms, especially POTS. Yes, so again, same response there. And I wish I could say your name, Andra, I'm just going to say. How can we differentiate between just hypermobility and EDS, and how does each impact our treatment rehab process? Well, that would only be through genetic testing, but it doesn't really make a difference for me and what I do. Now, there certainly may be differences in the type of EDS that you have, and that can affect other parts of the body, for instance, aortic aneurysm, etc. But for my purposes in treating craniocervical instability, hypermobile is hypermobile. So that's just taking a Beighton score online. And as far as affecting treatment rehab process, it doesn't, other than hypermobile patients tend to take more treatments to get to the same place, but they end up in the same place as non-hypermobile patients. Anja, do you know of any clinics which do DMX-like imaging in Europe, UK in particular? Dr. Hernandez recently came up as an option and was wondering what your opinion was on the matter. I don't know Hernandez. Maybe if you could tell me the imaging center, that might ring more of a bell for me. But if you go on to my YouTube page, which I'm pulling up right now. So if you go on to YouTube, let me get there here. So if you go on to the YouTube page, and if you just type in here DDR, there's this whole thing in here and how to video in here and how to use X-ray and DDR, which is dynamic digital radiography. But you can also use X-ray to diagnose craniocervical instability. So I would encourage you to go on to my YouTube page there and download that or watch that, because that's instructions not only for the patient, but for the imaging center to try to replicate DMX views using regular X-ray that would be widely available throughout Europe. And then again, as I always give a plug for it, I might as well do that now. Reddit, RPICL. So if you want to ask questions and get answers from me that are more formally written than just, sort of the rapid fire response we do in Facebook Lives, as well as see if things have already been answered, join this Reddit thread, RPICL. You can search here for an answer. So if you wanted to look at DMX in Europe, couldn't find anything there. Let's just look up DMX. So lots and lots and lots of, here we go, new video on how to use X-ray or DDR as a DMX substitute. So again, that's there, for example. So I'd encourage you to go on there, start asking questions, because I've already answered hundreds of questions on there. So it lives as kind of a digital repository of questions and answers about not only PICL, but just about CCI in general. Anja, do you see any benefit of hyperbaric, hyperoxygen chambers in treating CCI? I don't think they're going to treat CCI. I put it in the category of probably not going to hurt. Meaning I don't know if it's going to help, but it's probably not going to hurt. So you may as well give it a try if finances are not the driving issue. If finances are the driving issue, I probably wouldn't spend my money there. AT, the ligament healing process with PICL can take months. What about for muscles, tendons, aponeurosis, etc.? These heal faster, similar timeline as ligaments. Usually faster with those types of structures. AT, if a specific subject muscle is constantly dysfunctional in general, is it more likely ligament laxity is contributing to this rather than a problem with the muscle itself? Yeah, either that or the nerve going to the muscle could have a problem. For example, the fascia around the muscle could have a problem. Those are the things to be thinking about. Lindsay, I have a lot of pain in the atlas plus halfway down the neck. I believe the stellate ganglion is getting irritated by the callus and arthritis that's growing in that area. Would this procedure help? Well, the stellate ganglion doesn't live there. The stellate ganglion lives much further down. So that's a different ganglion. That's the superior cervical ganglion. The stellate ganglion lives way, way, way down here. So it doesn't live up near the atlas. Will this treatment help if stellate ganglion is catching on an area where callus or arthritis is growing? Don't think that that's realistic, Lindsay, simply because the stellate ganglion lives on top of the longus coli muscle, and the longus coli muscle would be on top of any arthritis there. So at the end of the day, there's a buffer between those two things. AT, a couple of weeks out from PICL now. I know we had some conversation possibly taking it easy on aggressive CB retraction earlier on. Any thoughts on reducing Dinerol at this point? Yeah, AT, like I said, you're kind of off of our normal treatment plan, so hard for me to say accurately. Diana, hydroxynteno, can you do this when we get the PICL? Certainly can. Yes. Diana, can you inject the accessory nerve to help healing with nerve damage at the PICL? We can. The accessory nerve lives on the outside of the sternocleidomastoid there, kind of opposite the area we're talking about, but it can be treated as well. Can you do a stellate ganglion block with PICL? I wouldn't do a stellate ganglion block because I think that just adds risk. We would treat the stellate ganglion with platelet growth factors because I believe that's a much better, lower risk approach than physically numbing the stellate ganglion, which has the added concern of a code for the patient. Lindsay, the fight or flight for nerve damage is definitely not PTSD. The symptoms are similar, but you can be in the state of it. Yeah, so Lindsay, the PTSD I'm talking about was in soldiers. So stellate ganglion block started for use in a military population where they had PTSD literally from war fighting. So that's the PTSD that I'm talking about. I posted your PRP C1 through 7 for Dr. Silva. He treated ligaments, tendons, capsules, 5.5 overhang on both sides. I feel a great improvement. PRP is restored. Headaches, fashions down for more than 6 hours now. I still feel slight nausea and tension when I turn my head too far side. My question is I don't see the rest of it. So I think it got cut off here, Elias. But again, the good news is that it'll treat a lot of symptoms, but we're not going to treat the overhang by doing those sorts of injections, meaning that's not going to deal with the excessive motion at C1, C2. You can't treat that way. But again, the good news is it can make the facet joints feel better. It can make the tendons feel better, the muscles feel better, so that can reduce some symptoms. But when you're turning your head one direction or turning your head the other direction, you're pushing those ligaments to their maximum, and that's when that overhang is coming out. So in order to treat that portion of it, you would need PICL. We're not going to be able to treat it with just posterior injections. Hannah, Dr. C, for symptomatic facet joints, would you favor bone marrow or PRP? Yeah, usually most of my patients who get PICLs can't tolerate bone marrow in their facet joints, but some patients can. So for those patients that can, we'll use bone marrow. But for most patients, we use PRP because patients, when they get bone marrow and facets, certainly a lot of the patients I treat with CCI really seem to struggle. AT, learned from last visit, the right obliquus caput spear muscle is a major root area dysfunction. Can occasional dry needle acupuncture of this area help restore function while healing? Nobody really knows the answer to that, whether or not dry needling that particular, or dry needling a suboccipital muscle after a bone marrow construct injection is a good idea or a bad idea. So I don't know, AT. It's not something I would recommend. Joanna, can the vagus nerve create that the heart makes double beats every third beat? Yeah, Joanna, you'd have to get that checked out as an isolated heart problem with a board certified cardiologist before I would make the claim that your vagus nerve had anything to do with that. Lindsay, is there a pillow you recommend for CCI patients? My neck is unstable regardless of which direction I look or tilt my head. No, Lindsay, that's pretty individualized, so I don't recommend specific pillows. Very, very, very individualized for the patient. So really just got to try a bunch of them and see what works the best for you. We can probably get out of that screen here. Anja, concerning hypermobility EDS, I was initially diagnosed with ledge EDS type 3, but after speaking with people and doing some tests, they conclude I don't have it. Gotcha. Could you advise your thoughts on IJV compression surgery or PICL for CCI if you need both? Doesn't matter in what order. Yeah, IJV decompression is a bad idea for patients with craniocervical instability. It's a bad idea because it leads to more instability in the front of the neck. So I wouldn't recommend that any of my patients get IJV decompression if they have craniocervical instability. You know, the fix for IJV compression with craniocervical instability is to treat the craniocervical instability. 80–90% of the time it goes away, and then only then, if it's still around, would you want to get decompressed, because you're going to cause instability by decompressing the patient. Mark, what advancements do you see in the next 20 years in regards to MSK issues and HEDS? Yeah, probably gene therapy. I think we'll see vector-based gene therapy come out for EDS probably in the next 20 years. Now, a lot of that's going to depend on how restrictive the regulatory space is. Realize that the gene therapy regulatory space got sort of just blown up with a thermonuclear device, if you will, in the 1990s. The FDA had approved a gene therapy. A child was killed because it was the very early days of gene therapy. We really didn't know what we were doing. And then that put like a 3-decade kibosh on additional gene therapy drugs. We are now coming out of that cold freeze, if you will, on gene therapy. And, we could see some interesting gene therapies make it to the market here in the next 5 years. And then obviously gene therapies for things like EDS wouldn't be far behind. Anja, so was left confused as to where this makes a drastic difference. By the way, my name is pronounced similar to Italian. Andrea. Gotcha, Andrea. So I think you were talking about HEDS, but it wouldn't make a drastic difference. Elias, also, Doc, what is your opinion on carnivore diet for healing? I think any low glycemic diet that you can go on, meaning low sugar, low refined carbohydrates, is a good thing. I think it's probably the effect of blood sugar stabilization more than eating lots and lots of protein that would be helpful. Jacob, I had my first PICL 6 months ago. I've had 50, 60% improved my symptoms. I was inflamed, been able to get out of the bed for 5 months post-PICL, but still not sleeping well, unable to sleep deeply, and I'm still unable to turn my head. When I attempt clock exercises, I can't move my head and become exhausted. Should I keep trying physical therapy? Yeah, so the average number of PICLs is, if we're talking about a real PICL procedure performed in Colorado, again, I'm not talking about fake PICLs performed in Europe or elsewhere, but if we're talking about a real PICL procedure, it's going to be 2 to 4 PICL procedures. And certainly sounds like you're probably in that category of needing another treatment to get further down the road so that you can start to participate in active rehab. Guys, I'm just going to take a second to remind everyone to like, share, subscribe this, because that's how we get this out to more patients. Realize that if you found this content, you're lucky, right? Because for each one of you watching this that has CCI or problems with their vagus nerve or other issues, probably 100 patients aren't going to find it because the algorithm isn't directing them to it. So the way to get the algorithm to direct them to it and help other patients and pay it forward is to like, share, comment, subscribe here. Mark, do you see any role in doing prolotherapy as a preventative measure in HEDS, i.e. injecting the supraspinous and infraspinous ligaments of a patient who doesn't have any gross instability? I don't think that's a good bargain. Listen, I think if you've got mild joint problems, then those sorts of interventions are a good idea. I'll give you a great example, right? This weekend, I was lecturing at a conference. There was a new kit there, PRP kit. Someone wanted to try it out. I was the first patient for that new FDA-cleared PRP kit, and my right knee is in a huge problem. It's got mild arthritis, some mild instability, but I had no problem getting a PRP injection in it because I know I've got a mild problem there. I want to keep it as good as I can keep it. So that kind of preventative care is fine. But for asymptomatic people, I think it's a bad idea, especially if there's no instability. Andrea, Dr. Juan Hernandez, Sagrada Familia Clinic, as far as I know, allegedly does DMX-like imaging in Europe. Website unavailable at the moment. Yeah, I'd have to look and see because I've not seen things from there. You know, really what I tend to see from Barcelona is just the CBCTs, inflection and extension. I think those can be helpful. The 3D reconstructions do nothing for me, or an attempt to look at C1, C2 facet joint overlap and rotation is not an accurate way to diagnose C1, C2 instability in my opinion, nor is looking at C1, C2 rotation. But the flexion extension CBCTs are quite helpful out of that clinic in Barcelona, and that would be Gillette's clinic. As far as Juan Hernandez's clinic, I haven't seen anything. Happy to take a look, but I haven't seen anything that I recall. Mark, I know you mentioned that the facet capsules are not major stabilizers. It's also true for HEDS patients. That patients without HEDS that rely on their ligaments capsules get torn. Yeah, same thing, Mark. Not major stabilizers of the CCJ. You know, it just doesn't make any sense that they would be, right? For example, the C1, C2 facet capsules, by definition, are super loose. Otherwise, they wouldn't allow half of your neck rotation. So they're not going to be prime targets for stabilizing much of anything. Now, I'm sure you can do cadaver studies where you go and cut them, and then you try to, wrench the head over, and the head goes a little more. But that's not how we're using our ligaments in reality on a day-to-day basis. AT, thanks for your time, Doctor. Probably send an email. Great. Lindsay, what is an example of flare-up after PICL treatment during? My symptoms seem to be different every day. Not sure what that one means, Lindsay. Maybe rewrite that because I don't have a clear sense of how to answer that one. Joanna, is HBOT okay when I have AAI CCI? Yeah, Joanna, I don't see any contraindication in general for patients who have AAI or CCI and HBOT. Do I think it's going to make a tremendous difference for that patient? I don't. So if you have limited resources, I'd probably save your funds and do something else like targeting the ligaments that control that area rather than spending a bunch of money on HBOT. Lucas, hi, Dr. C. My daughter has HEDS, although mild and very functional. She's starting medical school, DO program. Congrats. I know that's very difficult these days, so congratulations. And she is scared about the OMM part of the curriculum. She doesn't want anyone manipulating her neck for obvious reasons. Yeah, I would agree. She doesn't have CCI, but doesn't want to get it during OMM classes or able to write a letter so she can show. Yeah, Lucas, she'd have to be my patient in order for me to do something like that. I can't write a letter about a patient I've never seen. That's not ethical or even legal for me to do. Casian, are there many centrifuges you know that can give both a high concentration of PRP, PPP, and third generation lysate? So we're talking about different things here and some confusion about what those terms mean. So let's define them. So platelet-rich plasma is something that you can have low concentration, medium concentration, high concentration of platelets because you're concentrating platelets. Platelet-poor plasma is what's left over after you pull the platelets out. And so it's what it sounds like. It has less platelets or no platelets compared to regular blood, platelet-poor plasma, PPP. Third generation platelet lysate, there's no kit that makes that. That's something that can only be made in a lab-based process, but it's made from platelet-rich plasma. So again, different things there. As far as kits that make high-dose PRP, there aren't many on the market, frankly. There's only a handful. The vast majority of kits out there that a doctor's office can buy make really bad low-dose or moderate-dose PRP. Why do doctors buy those kits? They're dirt cheap. You can literally buy them for pennies on the dollar. And the patients, frankly, don't know the difference. And if you don't have much ethics as a doctor, why not just buy the cheapest kit that satisfies the term PRP? Obviously, you wouldn't do that if you were an expert in this area, but most of the doctors offering care aren't experts in this area. They're just looking for little extra cash on the barrelhead. So be careful out there. Joanna, Hernandez used the same x-ray clinic as the rest of the Barcelona doctors. Their DMX are not as high. Solutions USA is not as high. Yeah, I haven't seen anything out of that clinic that would qualify as a DMX or tries to look like a DMX, but happy to take a look. Lindsay, what is an example of flare-up after first PIC on my eyesight is bad? Sorry for the typos. So again, flare-ups follow that bell curve distribution, right? Bell curve is one standard deviation. The mean is most of the patients have 3 to 7 days of a flare-up related to a PICL procedure. Then you get the 2 standard deviations from the mean. You've got people on one end who barely know I did anything, and the people on the other end who have much longer flare-ups that can last weeks. And then we get to 3 standard deviations from the mean, and we get to a very tiny group of patients on the flare-up side of that bell curve who might be flared up for months, but that's a tiny percentage of patients. So it really depends on where you fall. Obviously, most people are going to fall 1 standard deviation from the mean. You'll have some people falling 2 and very few falling 3. Kimmy, is there a way to tell without imaging if I have a lumbar muscle strain or if it's herniated slip disc? Been hurting for a week now, no apparent injury. Certainly, I could in the office tell if there was a high likelihood of a bulging disc pressing on a nerve. As far as a patient telling that obviously might be much more difficult. But for an experienced provider that sees lumbar spine issues, like interventional spine provider, that should be pretty easy to say this is high likelihood to be a herniated or bulging disc causing nerve compression versus not. Snowmass, would you expect more pain or trapped scapula after PICL as the cervical ligaments are weaker going through the phases before reorganization? Not so much more, but I think what we tend to see is either patients go through an initial flare-up or they go through that honeymoon period. And I think for a lot of patients that go through the honeymoon period, when the honeymoon period's over, they feel like they're a little worse, but really it's only worse compared to how much better they felt right after the procedure. So I think that would be the most common explanation for what you're describing. John, is there any patient population that gets worse after a PICL? No specific patient population other than fragile eggs. Fragile eggs are essentially sensitized patients. And one of the reasons why the large flare-up rate after PICL has gone down so much is that I pick out the fragile eggs down, the essentially sensitized patients, and use a less is more approach in those patients. So we do a lesser procedure until we can get them to the other side of feeling better, and then we can integrate more. I think I got that one already there. Jacob, I just want to acknowledge what a groundbreaking actual solutions your office is providing. Your passion for the PICL, all involved is outstanding and so comprehensive. Thank you, doctor. See, you guys are the best for regenerative medicine. I can say this because it took me a year to find you guys and saw a lot of doctors out there, no idea what they're doing. Thank God and bless you. Well, thank you, Jacob. That's really, really nice. Yes, I think what Jacob's bringing up is there's a lot of professed expertise in regenerative medicine, but that's someone who learned from 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 us, meaning that we were the first people on earth to do most of these procedures 20 years ago. I was the first human on earth to do most of them myself. And then, we had 18 years ago, a few other doctors adopt them. And then we had a few more doctors adopt them. And then it kind of exploded from there. But, it's like a bad game of telephone sometimes. When I just came from a medical conference lecturing. And when I talk to some of these providers, the problem is that, they're fifth, sixth generation removed from the original guy who invented the procedures, and they didn't get the memo on everything. So their knowledge tends to be a bit less than it should be. And that's if they're taking the time to go to medical conferences. Most of the guys offering stuff in this area, the men and women offering stuff in this area don't even do that. Lucas, Dr. Centeno, I meant actually setting up a telemed appointment with you and she'd go through. Yeah, Lucas, the telemedicines are not for that. They're for trying to determine if a patient can be seen for a procedure we offer. So we don't do telemedicines as some sort of expert consultation service. Because if I did that, I wouldn't have enough time to get the actual CCI patients in. And that would be a real tragedy because I just wouldn't be able to do it. I'd probably be doing that 75% of the day, and the number of PICL patients I could get into the office to be treated would go way down. So we don't offer that service. Now, certainly there are doctors that treat HEDS. And you may want to get in on seeing one of those. There's the Bendy Bodies podcast, for example, that she's not an interventionalist, but she's quite experienced in HEDS. So Linda Bluestein, she's come to our office and watched a PICL procedure. She sent a bunch of patients through the years. If you go to if you just look up Bendy Bodies podcast, Linda would be a great person to do something like that, because I think she fully understands that this happens in HEDS patients, and she also has a ton of expertise in HEDS and managing HEDS. So that would be a good relationship, I think, to establish going forward for sure for your daughter. Casey, what centrifuge vendors would you recommend? Depends on what it is you're trying to do. If what it is you're trying to do is to get high dose PRP, and you don't have the qualifications to be on the Regenexx network, which is only about 1 out of every 20 physicians who would have an interest, then I would say MSite makes a very good system. They can get to higher concentrations of PRP. It's leukocyte poor. Their platelet recovery is good. Better than that, it's going to be the Regenexx system. But again, you're going to have specific qualifications to get onto a Regenexx provider network that most doctors don't have. Mark, hey Lucas, there you go. Lindsay, can we use lidocaine patches on treated areas after PICL? Not the best, because lidocaine is quite toxic to stem cells. Having said that, you're probably not getting much lidocaine exposure to stem cells. So to the injected cells. So if you could avoid it, I would try to. If you had to use it, it's probably not a big deal. Snowmass, is it okay to take muscle relaxants or gabapentin after PICL for some relief? It is, yes. John, can I get a caudal epidural injection same time as PICL and my SI joint injections all the same day? Yeah, John, that's not a problem at all. We frequently treat multiple areas when we're focusing on PICL. And now the only caveat to that is going to be in the 1 in 20 patients we see or so who are essentially sensitized fragile egg patients. And for example, that's the kind of patient that might get a massage and be in bed for 2 weeks because of the severe pain caused by the massage. So if you're not in that category, then yes, we can certainly treat all those additional spots and areas. Lisa Marie, how soon after first PICL can I have the rest of my spine and SI joints and hands treated? Not sure what you mean there, Lisa. Do you mean treated with injection-based therapies? If so, what kind of injection-based therapies? Do you mean treated with manipulation, physical therapy? Maybe a little bit more info on that one. Lindsay, when should myofascial release therapy be helpful after PICL? A lot of that's going to depend on how deep and aggressive that is. So if it's myofascial release therapy more similar to Rolfing, then I would wait a good 6 to 8 weeks. If it's just standard myofascial release therapy where they're really not going to be getting in there with their elbow, for example, i.e. they won't really disturb the high upper neck, then I think literally just as soon as the flare-up from the PICL comes down. Yeah, well, caudal with platelet lysate. I think he's talking about 3rd generation platelet lysate, which is what we would use. We wouldn't use corticosteroids, high-dose corticosteroids for a caudal at this juncture. Lindsay, is malaise just feeling sick all the time, seeing a patient with CCI, or this be another area? I mean, it can, Lindsay, for sure. We have lots of CCI patients that feel sick all the time, but again, we always ask that they get worked up for specific things. So our average patient, for example, might have tachycardia. They've gotten worked up by cardiology, or they might have severe GI issues, and a gastroenterologist says, I don't know what's going on. Or they might have had a rule out cancer workup, or they had a CBC, or maybe other types of blood tests just to make sure that there wasn't some sort of blood dyscrasia or anemia or those sorts of things. Snowmass, do you offer stellate ganglion with PICL on the same day? If not, why? Yeah, so when we treat the stellate ganglion with third generation platelet lysate, that's done at the same time as we're treating that vagus nerve area and doing a superficial cervical plexus treatment usually. So all of that's same day as the PICL. Definitely. Lala. Hello. Can we see subluxation without damaged ligaments on flexion extension MRI? When we're looking at flexion extension MRI, we're looking for movement beyond certain norms. And if you have that movement beyond certain norms, for instance, a translational BAI of 4 or greater, then you would be able to see craniocervical instability on flexion extension MRI. As far as the kind of subluxation I think you may be talking about is, can you see chiropractic type subluxation on flexion extension MRI? And I think probably not. Having said that, Scott Rosa is able to do it. So it's outside of my area of expertise. Let's see. Mark, funny story. You're talking about so-called experts. I actually go to med school right now, DO program, and one of my professors is old school sports medicine physician who did blind prolo on my shoulder and claims it was a cool way to know the anatomy. Yeah, I think, again, for the 1980s, 70s, and 80s, when ultrasound really wasn't good enough to follow needles, I think that's fine. By the 2000s, we started seeing widely available ultrasound machines. And certainly now you can pick up a used one on eBay for $10,000, a good, nice one. Oh, well, not nice one, but, passable. Something certainly 3 or 4 years old. There's really no excuse not to use ultrasound, so I wouldn't agree with that, obviously. Liam, if CCI is affecting some of your shoulder muscle nerves, causing atrophy of those muscles, what are the chances of getting those muscles working optimally? Liam, a lot of that depends on why the atrophy is there. If the atrophy is there because there's some irritation of a nerve, then I think you could get it to turn back on. If the atrophy is there from actual severe damage to the nerve, then probably not. Or if the atrophy is there simply because there is overload of the shoulder all the time. And then again, might come back. Lisa, I've seen you for PICL, but multiple bulges, partial herniation, lots of pain. Lisa, I think you probably talking about up there. So yeah, so we can treat all of those different areas, assuming you're not in that fragile egg category. Lindsay, do post-concussion symptoms sometimes get better after CCI? Yeah, Lindsay, in my experience, most of what's called post-concussion symptoms are usually coming from the upper neck anyway. So the answer is usually yes. BP, have you ever observed the stellate ganglion or stellate procedures to improvements in spasms in patients with a current or recovered spinal cord injury? Have never seen that. Wouldn't use the stellate ganglion for that type of treatment. Okay, guys, I know we're a little bit later today. I apologize for the late time, but again, I had some lectures I was given down in Arizona and just got back from the airport. So I did want to get this out there today because I know a lot of people, depend on this time to get their questions answered every week. Any other questions out there? I'll be happy to answer those. In the meantime, I will again give a plug for RPICL. So that means Let's get over there here. So this is the Reddit subreddit thread I have put together for the PICL procedure and all things CCI. There are just tons and tons and tons of questions and answers here that I have done already. You can search all of these, find answers at 2 a.m. to your heart's desire. And the goal is to get enough patients on here. We have 206 members now. Hopefully we get 1,000 members here in the next 6 to 12 months. But the goal here is to try to get every possible question about CCI and PICL answered so that there is a repository for patients to search to their heart's content about, all things CCI, all things PICL, CCI injections, posterior injections, etc. So please join this Reddit and add to that, because this is now a long-term project. And 10 years from now, when I'm long since retired, hopefully this will still be here as a repository for great information that patients can access. But that's only going to happen if we get lots and lots of people on here asking lots of questions. I can't think of every question a patient might have. I obviously know some good ones, but this allows me to not have to think of every single question a patient might have. Quick question. Do you recommend PMR sports medicine or family medicine plus sports medicine applying to residency next year? I think PMR sports medicine is by far the better way to go. The rationale is in PMR sports medicine, you can get spine exposure, most of those programs. I'd choose a program with spine because I call sports medicine docs half a doc, meaning that that there's no such thing as a peripheral joint problem in my book that doesn't involve the spine in some way, meaning it's all one machine. And if you want to treat the whole machine, you've got to learn how to do spinal injections as well as peripheral joint injections. So don't be half a doctor and just focus on the peripheral joints and not ever get any education on how to treat the spine. That would be my focus there. And so that's why I think PM&R sports medicine, you're going to get that. Family medicine sports, you're not going to get that. Joanna, less than three. Thank you. Barcelona book meeting. Gotcha. Lindsay, is neck curvature, scoliosis, or other physical therapy treatments the first to work on after PICL? Yeah, so I have a whole program on that. And so if you go to the videos here on my channel and you scroll down not too far, you're going to see all these rehab videos. They look like this. I spent, probably 24 hours doing all of this. So I'd really avail yourself of this so that you can, figure out that whole rehab program, because it's all there. So I'd really recommend you go there. Do you inject collagen solutions? No, we do not. In Turkey, my doctor inject collagen in order to get quick response. Of course, he can't inject transverse ligament, only laminas. Can it be more effective? I don't think we have any evidence that injecting collagen will do anything at all. Liam, what is your best way to determine damage to the shoulder neck nerves? Good old-fashioned hands-on exam, Liam. We might add some ultrasound into that, and/or obviously look at your MRI as well. But no substitute for a hands-on exam, just not. I wish there were, but I think it's one of the lost arts of medicine, and one of the reasons why a lot of physicians get very confused by these chronic neuromusculoskeletal conditions, because they don't have the ability to do a thorough hands-on exam. They just like reading someone else's interpretation of the MRI and doing a quick exam. But diving in deep on that hands-on neuromusculoskeletal exam can answer a lot of questions. Thanks so much, Dr. Centeno. At this hour, you share this because there's hope. Happy to do it, Lindsay. Lala, can we identify which ligament needs an injection with CBCT in Barcelona? CBCT with flexion and extension is what's required. That will be able to identify CCI type 2A, CCI type 1A, and 1C, as well as 3A and 3B. It will not be able to identify CCI type 2B, which is side-to-side, or instability at C1, C2. And regrettably, that's a pretty common type of CCI that technology will completely miss. It'll go over the head of that technology. So it's a good start for sure, CBCT with a flexion extension, but it's not going to identify one of the more common types of CCI, regrettably. Happy to do that as well. Any help for intracranial hypertension, probably headaches. Yeah, the first question is, are they really intracranial hypertension? Usually they're not. To see translation of C0 to C3, do you need more than just flexion extension? Data on my imaging report that's supposed to show C0 translations is missing. Yeah, I don't know. Are you talking about flexion extension x-rays? Or you're talking about a flexion extension MRI? If there was movement in translation, it should be there. But again, just realize that not many radiologists are all that clued into looking for sub-surgical things. So if they saw lots of translation in flexion and extension that clearly needed surgery, they would call it out. If they saw 2 millimeters at C2-3, which is abnormal, they're not going to call it out. Lindsay, does DMX hurt patients more than I seem to get worse after these? Just head movement. I mean, that would tend to mean that you're a little bit in that fragile aid category, right? So that's just head movement type things. So that's important to realize. Liam, thanks, Doc. Without all this info, a lot of people would feel so lost. Appreciate it. Thank you, Liam. Okay, guys, so we are at the hour. I appreciate all your questions today. Again, if you get a chance, go on that RPICL. Lots and lots and lots and lots of questions there that have already been answered. I want to get lots and lots and lots and lots of other questions to answer. So join that. I'll be here next week, hopefully at the regular time, because I won't have a medical conference to lecture at next weekend. But thanks for joining me late today, and thanks for all the great questions. Thank you.